In a former life, I was an internist, but DQ slapped all that out of me rather quickly. It wasn't pretty, but now I consider myself an emergency physician. And in my next life, I actually picked up ultrasound. It was after residency that I became more interested in that. And I actually went back and became an ultrasound tech and then took over the program at Columbia and Cornell. So it's been kind of a third lifetime for me, really. So anyway, I'm happy to be here with you today. Welcome. And today we're going to talk about general abdominal scanning. And we have a lot to talk about in this lecture because we're going to go over three things. We're going to start and we're going to go over, first of all, aorta ultrasound. And there's a lot to talk about there. The main clinical question is, as John told us, we're really doing goal-directed ultrasound. I don't expect that when you do your ultrasound exam, you're going to say, well, it looks to me like there's a superior mesenteric artery thrombus, right? That's not what we're doing. You're really just looking, is there an aneurysm, yes or no? In terms of gallbladder sonography, you want to know, are there gallstones? Is my patient who's just coming in after eating the burrito with the right upper quadrant pain, does she have gallstones? Does she have cholecystitis? Next, how about those flank pains? We talked about trauma a lot in the last talk. I don't know, place I work, we tend to see a lot more flank pains coming in. I can tell you it's about 6 or 7 every shift. And ultrasound offers you another way of managing these patients, perhaps without doing a CAT scan. So with that being said, let's go to the definitive source for emergency medicine education, which I think, and let's watch a short clip here.
BP's 200 over 140. Try to relax, Mr. Reynolds, okay?
Ultrasound's ready.
All right, take a look. Tell me what you see.
You want me to get him started on beta blockers?
Ah, you read my mind. Esmolol, 5 grams and 500 mil. And 4 of morphine.
It's a AAA. I'd say about 4 centimeters.
Dr. Lewis, great. I was afraid I was going to miss you.
I'm on till 2.
You know, it's not going to be the same around here without you.
Oh, stop it. It's hard enough. Okay, Dr. Doyle, give Dr. Carter the bullet.
72-year-old male, history of hypertension and hypercholesterolemia, 1 previous MI. Pain began in left lower quadrant a week ago. The ultrasound shows an abdominal aneurysm 4 centimeters.
Yeah, we'll take him off your hands for you.
Ah, not so fast, Dr. Carter. Check his femoral pulses.
The ultrasound indicates surgery.
What do you think, Dr. Doyle?
I agree with Carter. There's a chance of rupture.
10%. How are his femoral pulses?
2+ bilaterally.
So he has good blood flow to his lower extremities.
But the ultrasound indicates a risk.
Shows no leakage. Let's get a CT to confirm it.
So you want to manage it medically?
Yes, I'd like to try. The machines can give us test results, but they like to keep us around here for diagnostic judgment.
Okay, guys, show of hands. How many people want to manage this patient medically with a AAA that's rupturing? Show of hands. I'd say we send them all back for another residency, right? Okay, thank God for physicians, right? The actors haven't replaced us completely. What do you think they're talking about there, guys? What can we manage medically within the abdomen? Any ideas? Involving the aorta? Any thoughts? I think they're talking about dissection. Okay, but that's okay. We'll give them the benefit of the doubt. Anyway, let's go on a little bit in terms of what we're actually going to do for aorta. Let's start with the pictures that I love and actually got me through anatomy in first year of medical school, those from Frank Netter. Well, in the abdomen, we're going to have 2 tubular structures. Remember that to the right, we're going to have the inferior vena cava. It's going to be thinner walled and pulsatile. To the left, we're going to see the aorta. Now, there's a lot of branches off the aorta, and while I don't want to make that the primary focus of this talk, because that's very confusing, I think, we should have a general idea when things are coming off. The top one is going to be your celiac axis, and I'm going to show you what that looks like on an ultrasound clip. As we run the aorta down from the top, we're also going to see the superior mesenteric artery, okay, and you can see that coming off. Now, that's an important landmark because right about that level is where the renals come off, and most AAAs are going to be infrarenal, right, guys? Okay, below the level of the renals. So we really have to start paying attention here. And we're going to watch the aorta all the way down to bifurcation where it turns into the paired iliac arteries. Okay? So now that you have a general idea in terms of the branch points of the aorta and its alignment with the inferior vena cava, let's look at an overlap between the inferior vena cava and the aorta. Okay, so this one actually just Netter put the 2 together. And there's the aorta to the left, okay? And there's the inferior vena cava to the right. Notice there's a branch that comes across. This splenic vein actually comes across, okay? And again, I don't want you guys staying up tonight, you know, instead of shooting craps or whatever you're going to do here in Vegas, going, oh, my God, where's the splenic vein? But I do want you just to have a general idea that there's a lot of vascular structures. Your main emphasis needs to be back here, looking at mainly the aorta. And again, thank you to Frank Netter. Without him, I think I would have failed anatomy, and Dika wouldn't have had to put up with me for 3 years, right, Dika? Okay, so let's go over
So
Cliff.
now let's review the ultrasound exam of the aorta. Let's first begin by reviewing the relevant surface anatomy, and remember that we can pick up the abdominal aorta as it exits the thoracic compartment at about the level of the subxiphoid process. We can follow it down to bifurcation at about the level of the umbilicus. We'll begin with the probe marker towards the patient's right side in the short axis plane. Here I'm just motioning to the marker dot on the probe. And place the probe into the subxiphoid position. You'll need to press down to push the gastric gas out of the way and to adequately image the aorta. And notice here on the screen we see the spine, and on top of the spine the pulsatile thick-walled aorta, and to the right, and to the left we see the inferior vena cava. We'll continue our exam down caudally towards the patient's umbilicus, moving the probe down the center or midline, gradually displacing bowel gas by exerting pressure with the probe down towards the spine. We'll image all the way down to bifurcation at the level of the umbilicus, and there you just saw the iliacs. We can also follow this up by imaging the aorta in the long axis configuration to adequately investigate for an aneurysm. Notice here I'm motioning towards the aorta, and I'll just put color flow Doppler to show the turbulent flow within the aorta.
Okay, as John talked about, there's a lot of buttons on the machine, and power Doppler is one of them, and you can play around with it today. I don't think it's really necessary, but it is there if you definitely want to document that it's a vascular structure. Okay, with that being said, let's go over what the actual ultrasound images look like. Okay, so first of all, we're at about the top of the patient, right below the subxiphoid process. And our first landmark is going to be, these are just the markers just showing you. I have the marker dot here aligned towards the patient's right. Okay, the first landmark, very important, is the spine. Okay, notice the spine sits there. And notice it has a hyperechoic light appearance. The ultrasound beams come down and accumulate on the anterior portion of the spine. They can't make it through, and it lights up kind of white there. So right on top of the spine, we see the two pulsatile structures, okay? To the right is the inferior vena cava. To the left is going to be the aorta. Now, in this one, we talked about the celiac axis, and the celiac axis, the ultrasound appearance is called the seagull sign. You guys see this right here? Does that look like a seagull, or am I hallucinating? A little bit, right? Okay, so that is the seagull sign. That's the celiac axis coming off right there. Okay, so that's a top image of the aorta. As we go a little further down, we're going to see the portal vein coming across the top. And again, we have our spine. Okay, so again, the workshop today, I want you paying attention to where is the spine, and there's the IVC, and to the left is going to be the aorta. Notice that, whoops, let me go back again. Sorry.
So now let's review.
Sorry about that. One important structure that I wanted to show you there was the portal vein just looping across, and it's going to be coming right over the top. Again, there's the celiac axis. You'll notice the celiac axis on this next one right here. Okay? And here's actually your celiac, okay, again. And this structure right here is your portal vein coming right over the top. Okay? This little structure here is actually your superior mesenteric artery. And I'll show that again on a better image coming up. So again, your spine, IVC, and you have your aorta over to the left. Okay, so that's the most important thing. If you can really just find out where is the aorta, you're going to be doing fine in the workshop today. Okay, so here's just another clip showing, again, we have the, go forward here. So again, there's the portal vein. Now this next image right here is going to show basically the celiac down to the renals. Now notice here, what is this, guys, right here? Spine. Okay, very good. What is this little tubular structure right here? So this is to the right, this is to the left. Inferior vena cava, right, guys? To the right. And this structure right here? Aorta. Very good. Excellent. Now you're going to see a branch coming off. There's a celiac. Right here is a superior mesenteric artery. Notice it's wrapped in fat, so it has kind of echogenic white walls. What's interesting is right after that comes off, we actually see the renals coming off. Now, you're not going to see the renals on every patient, but if you do, it's a bonus, okay? You should just realize that you usually will see the superior mesenteric coming out, and the importance of that is now you're really paying attention because a lot of these are going to be infrarenal AAAs, and this is where you're going to start picking them up. Okay, let's look down to bifurcation. Okay, let's watch here. Again, here's our aorta right there. Here's our spine. Notice as we scan down past the umbilicus, what we see is the aorta bifurcating into the paired iliac arteries. Okay? So you really want to watch that aorta go all the way from the top, okay, from about the level of the celiac, all the way down to bifurcation. Okay? And we'll show you how to do that today. And there's just the aorta with the bifurcation. Very good. So now you know kind of how to the parts kind of put together. Now let's look at one clip where we scan all the way from very proximal to distal. Okay? So again, we're going to have our spine here. This is the left and the right. Okay? There's the inferior vena cava. Here's the aorta. Now we're coming down further down towards the umbilicus here. Notice, here we come, and there's the pairing of the iliac. So as we start at the top, celiac axis, right? The seagull sign coming off. Okay, watch that seagull sign here. Superior mesenteric artery. Portal vein comes over the top. And now we're going to come up to the iliac artery. Okay? So notice here the marker dots over here, and you can see that the aorta here looks very small. It's probably less than about 1 to 2 centimeters. Okay? So we're now going to talk about what defines a AAA. But before we do that, let's just make sure that we can also realize that we can image the body in 2 planes. And I think John showed that earlier today, that we can image both in short and in long. So this is just a long axis view coming up. And what I'm going to show you here is the long axis of the aorta from superior to inferior. Okay? And you're going to see there's the liver, okay, coming right here on the top. And you're going to see a couple of the branches. There's the aorta, the tubular pulsatile structure there. And notice we have the celiac axis coming back. It's actually going to be pointing kind of superior. And then we can actually see here the superior mesenteric artery going south. Okay, so short axis and long axis. Great. So now that we've gone through what some normals look like, let's talk about what we're actually looking for with a AAA. Okay? Now, the definition of a AAA from the textbooks is a aortic aneurysm greater than 3 centimeters. Okay? Once the aorta balloons greater than 3 centimeters, we can make the call. Now, for the textbooks, at about what level do we think we want to operate on these things? What do you guys think? About 5, right? So it's actually, if you look statistically, the risk of rupture is much greater than 5 centimeters. So while we call it at 3, many surgeons will not operate until the aorta becomes greater than about 5 to 6 centimeters. Now we're talking if a patient comes in and they have back pain and you look there and you see a 3.5 centimeter aneurysm, that could be the problem, okay? You may not have to wait until it's 5 because a 3 centimeter can still rupture. Now, as we talked about, the majority of AAAs are going to be infrarenal, and this is why we have to pay attention all the way down to bifurcation as we're scanning down through the aorta. Okay, in terms of measuring the aorta, generally we want to measure in short axis, and I'm going to talk in just another slide about the cylinder effect and how in long axis we can underestimate. And a very important thing here is you want to measure outer wall to outer wall. You want to include the thrombus in the actual determination of the size of the aorta. And I'm going to show you a slide also that's going to kind of show that. Okay, the cylinder effect. If you're trying to estimate the dimension of a cylinder and you're looking with long axis, you could slice it laterally and underestimate the size. Okay? That's why in short axis you can actually get more of a sense of where the largest dimensions are and adequately size it up. So this is why short axis is a better way of actually measuring the aorta than in long axis plane. That being said, I like to image in 2 different planes, but I usually take my measurements here in short. And that comes from a great textbook. If you guys are looking for a textbook to buy, Emergency Ultrasound, this Cosme and Kendall is a relatively new source. Very good book. Okay, so the other thing is there's really 2 different types of aneurysms. The first is the fusiform aneurysm, and this is your more common one. We have a diffuse dilatation of the aortic wall. Notice here, this is the less common, the saccule, where you have a little bit of an outpouching of the aortic wall. And you can see these. Actually, I have a clip of one. But this is your more common type right here, the fusiform. Okay, so what do you guys think of this one? Normal? Back pain? Send the patient home? What do you guys think? No, this looks kind of big, right? Here's the marker dots right here, all the way down to 4 centimeters. So you can see this is a pretty large one. We're just putting color Doppler flow there to make it pretty. You don't have to, right? This is enough, just the B mode or the grayscale. But notice as we look there, we can see the lumen. This looks kind of large. I was a little nervous when I saw this patient. And when we measured it, it was 4.8 by 4.99. So making the criteria for a AAA. Now let's look at this one. This is another one that I thought was kind of unusual because what we're seeing here is this is the actual lumen right here. And notice all of this right here. What is this here, guys? That's all thrombus, right? So if I only measured here, I would vastly underestimate the size of the AAA. That's why what you want to do is you have to measure all the way across with the thrombus. Now I'm just going to show some more pictures. We're actually just kind of making it pretty, the short axis view. Here's the long axis view. And you can kind of see the power Doppler. There's the lumen right there. But notice even on long axis, here's the extent of the aneurysm, okay? So if I put measurements there, the calipers, that's pretty big, right? Ouch, that hurt me, 6.3 by 6.16. So that's a very big aneurysm. And this patient actually got admitted and to vascular surgery for repair. Okay, so very large aneurysm there. And just very important, just remember, you could actually measure anterior, posterior, and also side to side, but in the short axis plane. Now here's an interesting one. This is actually a patient. She was 65. She presented to the ED with epigastric pain, and my resident came out of the room and said, you know, I think this is gastritis. I'd like to give Zantac and send home. And I said, are you sure about that? And of course, he knew me, so the next step was to get the ultrasound machine over there, and we took a look. And what's interesting about this is here's the aorta here. Do you guys see this right here? It's a subtle outpouching, but this is actually a saccular aortic aneurysm. There's just the superior to inferior. Again, long axis view, and you can see the little saccular aneurysm is coming out there, outpouching. And when we measured it, it was 4.45 centimeters. So what do you guys think? Does that make the definition of a AAA? It's greater than 3, right? So actually, this patient got admitted and had surgery as well. So a saccal one. Now, I think this is what they were talking about in the ER clip. I'll have to send them a note. I thought Deku was writing some of their shows. I think he stepped out. But we'll have to send him back through residency. Now, you can see here, this is a large aorta, right? Because here's the marker dots. You see it's about 4 centimeters. But do you guys see this thing going all the way down here? There's actually a flap coming all the way down the middle of the aorta. So this is the dissecting thoracic aortic aneurysm that was coming down past the diaphragm into the abdomen, okay? And I know it's very confusing, the DeBakey versus Stanford class, but, you know, I actually don't like the DeBakey because those 3 classifications make me nervous. The Stanford class, this would just be a B. It's a distal. And when we looked here in terms of long axis, okay, I'm scanning through the liver. Here's the aorta. Do you guys see that flap right there? Kind of moving around in the breeze there? So at Columbia, they were actually managing this medically. It takes a gun to the head of the surgeon to want to take this patient to the operating room. They really don't like to operate on these the distal dissections, if at all possible. So this patient was being managed medically. Okay, very good. So when a AAA ruptures, a bad thing, right? But the majority are going to rupture into the retroperitoneal space. And an important fact here is that many of these will compress the retroperitoneal structures. So you guys all know the classic teaching point of the resident who goes in and sees a 75-year-old patient with flank pain. You dip the urine, it's positive. The resident says, can I have some Toradol, please? And you're like, absolutely not, until we look at the aorta. And then you've got a AAA that's actually ruptured and compressing the ureter and causing a mimic of what you thought was a kidney stone. Now, Deku talked a lot about the FAST, but the FAST exam is not going to be positive with a ruptured AAA. Not in the majority of cases, because the rupture goes retroperitoneal. And we don't specifically evaluate this on our FAST scan. This was a kind of a scary case. This was a Cuban physician that I saw. And notice here, again, he's got an aneurysm. Do you guys see all this area right here? This is a contained rupture of the aorta. And he had some abdominal pain and actually syncope earlier in the day and then came in. And we put the probe there, and that's what we saw. And this made me very, very nervous. So the next step was to get him up, get some clamps on that aorta, right, and get this taken care of. So this was actually a contained rupture of the aorta. Okay, great. I guess we're going to save questions till later, but that is the aorta part. So write down any questions you may have for me about that. Let's go now over to next topic, which is going to be gallbladder ultrasound. Okay. And the question here is, how many patients every shift do you see with right upper quadrant and epigastric abdominal pain? Okay? I would say generally that's about 5 to 6 for me. How many of you guys are seeing on a routine basis stab wounds or gunshot wounds to the body? Is that like hands, routine every day? I mean, listen, how many gallbladders are you taking care of a day? Yeah, it's a lot, right? So this is very important for us. So let's go through this. Okay, again, we're going to start with a little bit of an anatomical overview, just remembering that the gallbladder is tucked in there under the liver. And oh my God, there's that portal triad, right? Very confusing, right, from medical school. Those 3 structures that your anatomy professor loved to pimp you on. I'm really not going to go too much into those except for just mentioning about the portal vein, which is the main vein bringing the blood back into the liver from the intestine. And as we go down, of course, we have the pancreas and the duodenum. And so there's a relation of the gallbladder and some of the ducts. Now, I really like this picture because, again, Netter, my favorite. And he had a nice picture here of the different parts of the gallbladder. So the top part is the fundus, and then we have the body and the neck. And this is very important because, guys, where would we worry about a stone? Would we worry more about a stone right in this area here or down here? What do you guys think? Down at the neck, right? Because it's going to block the outflow of bile down the cystic duct, right? That's what causes cholecystitis. But what if we have a stone that gets loose and goes down the common bile duct, okay? That could be bad, right? Because it could lodge right here at the confluence of the common bile duct with the pancreatic duct and cause GSP, or gallstone pancreatitis, okay? And this was also a favorite one of my anatomy professor. He loved the ampulla of Vater, okay, right there, okay, where the pancreatic duct and the common bile duct come together into the second part of the duodenum. So let's go over how to perform
the ultrasound exam of the gallbladder, begin with a standard 3 megahertz probe that you're probably already using for general abdominal scanning, like the FAST exam. Begin with the probe in the fast position with the probe marker towards the patient's head, and then move the probe up onto the patient's chest towards the midline, walking your way up the bottom of the liver until the gallbladder pops into view. Once you've identified the gallbladder, rotate the probe towards the patient's right shoulder in order to achieve great lateral views of the gallbladder from the fundus all the way down to the neck. Now, note here that I'm just rocking the probe in between the patient's ribs to achieve the best imaging plane of the gallbladder. Now, generally, it's important to interrogate body structures in 2 planes, and here I'm just going to rotate the probe so now the probe marker is down towards the patient's right side in order to evaluate the gallbladder in short axis view. Now, sometimes these lateral views with the patient recumbent can be difficult. And one tip is to move the patient into the decubitus position with the right side up. This will bring the gallbladder closer to the probe when placed into the subcostal position. Notice here that I'm right on the gallbladder, and I can then push the probe in towards the gallbladder to evaluate for the sonographic Murphy's sign.
Okay, great. So you can see how repositioning the patient makes a big difference, and bringing them the recumbent actually brings that gallbladder over towards you and allows you really to push in there and see if it hurts, okay? All right, so here's a normal exam. This is what it looks like, and here's the liver. Here's the gallbladder, and below there we actually see the inferior vena cava. The gallbladder I like to think of as a pear, okay? And it's a dark pear, because what is in the gallbladder? It is fluid, right, guys? And fluid is dark or anechoic on your ultrasound exam. So that's a pretty normal gallbladder. We don't see any stones there. This is actually a little kid. And notice he's got an interesting feature in his gallbladder. It almost looks like a bifid gallbladder, right? That's actually just a septa going down the gallbladder. And that's a pretty normal finding, and you'll see that as you look at more gallbladders. All right, now this is something that becomes a little bit confusing to some people, but I actually use this in a way to help me find the gallbladder. I do this because the gallbladder and the portal vein are intimately attached by something called the median lobar fissure of the liver. Okay? And while we're not really going to talk about, I have here just showing you where the common bile duct and hepatic artery. This is more advanced, and I don't want you thinking that you're coming out of a one-day course are going to be able to, adequately measure the CBD in 4 different planes, right? But what we can do is we can use the portal vein when we see that and walk our way up to the gallbladder, because in a patient who may have just eaten, the gallbladder can be small and very difficult to find, okay? So let's go over what it actually looks like in the relation of the portal vein to the gallbladder. So it looks like this. Here you've got the gallbladder to the top, and that's actually the portal vein, making up what is known as the exclamation point sign, okay? And right in the middle, we see a little white line, which is the median lobar fissure of the liver, and this is actually kind of walking our way up. Now notice the portal vein has got these white walls, it's got fat in the walls, and this differentiates from the hepatic veins, which are just black, okay? So when you see these little structures here that have white walls, it's the portal vein. And you know that you're very close at that point to looking up towards the gallbladder. That's just the inferior vena cava in the back. Here's just another view, again, showing the relation of the gallbladder. And there's the portal vein. And remember that the portal vein bifurcates into the right and left portal vein. That's just the bifurcation there. And again, we see the median lobar fissure right there. Okay, so once I find that, I can walk my way up to the gallbladder, and hopefully you have a chance to do that after lunch. And you can take a look. Because some of our patients may have had a large buffet lunch, and their gallbladder may be contracted. Okay, now, don't make the mistake of thinking that this is a gallbladder. Does that look like a clean gallbladder to you guys with normal walls? Okay. It's fluid there, but this was actually a liver cyst. So make sure that you're looking at the gallbladder. And also make sure when you see things that look abnormal that you're going to get a follow-up scan. This was a patient actually came with liver cancer. And notice the architecture has been replaced within the liver there. Okay, so gallbladder sludge. A couple words on that. It is the precursor to gallstones. It looks like a fluid layer. And the important thing here is that sludge with very small gallstones can result in hepatobiliary disease. Here's a clip of some sludge. You guys see this right here? Here's the gallbladder. Okay, there's the liver. And notice it's got kind of a fluid level. And you can see a little bit of the sludge up here. Notice that it doesn't shadow. Okay, that's very important. It doesn't shadow, but that is sludge. And given time, right, the right amount of incubation, like a fine wine, okay, that is going to turn up into gallstones. So what are the primary goals of what we're doing? Really, you're looking for gallstones. And just remember, gallstones are bright. They cast shadows off the back side. The only problem here is that very small gallstones, less than 3 millimeters, may not shadow. And typically, they're going to move when the patient moves, and they're dependent. So here's a picture of a gallstone in a septated gallbladder. You guys see this right here? So there's a gallstone. Notice the shadow. Okay, so positive gallstone. And here's no longer a gallstone. This is more like a montaña, a gall mountain. Okay, look at this thing. It's huge, and it's stuck right there at the neck. This is going to cause problems for our patient. Okay, and you can see there's the posterior shadowing. Now, this one is subtle, but this is a small gallstone just stuck down here at the neck. So this is why it's important today when you're at the workshop. Try to visualize the entire gallbladder, because you can see this could be easily missed. And that is in the area, this is in the fragile area of the gallbladder, because that could cause problems. But notice it's small, and you see the shadows right there. So a small impacted gallstone right at the neck. And here's one just showing the microlithiasis of small stones. And this patient actually had gallstone pancreatitis, so this was enough to cause problems for our patient. Okay. Now, Sarah told me in the back, Sarah Stamer said, don't confuse them with this. I think we're going to leave this more for the workshop. But typically, there can be a problem looking between gallstones. Bowel, as you know, is right up there against the actual gallbladder. And I think we're going to cover this more in the workshop. The main point here is that the bowel, when it comes right up against the wall of the gallbladder, can look bright and can mimic a gallstone. Okay, you guys see that right there? Whereas look here, do you see this right here is kind of it's definitely a white shadow definitely within the gallbladder. This is not clearly within the gallbladder. And notice these hard shadows, the clean shadows right off the back. Whereas these are, we say, kind of dirty shadows off of gas. But I'm going to leave that more for the workshop. So acute cholecystitis, what are we looking for? Well, the majority are associated with gallstones. Acalculous cholecystitis, pretty rare, right, in ED patients. You might see a patient who just was discharged from the ICU or an HIV patient, but pretty rare. Really, we're looking for gallstones. And what are we looking for in terms of cholecystitis? Well, the presence of gallstones with a positive sonographic Murphy sign gives a 92% positive predictive value for acute cholecystitis. This is an older paper, but one that I still think is very good. So 92%. Just when you push there, it hurts, and the patient has gallstones. Now, there's a lot of secondary signs of cholecystitis, such as a large gallbladder, a thickened gallbladder wall greater than 3 millimeters, pericholecystic fluid, or the presence of secondary just a large edematous gallbladder wall. But really what you should know is that the presence of these signs only increases your positive predictive value from 92% to 95%. So what does that tell you? It tells you that you can basically just look for gallstones and see if it hurts there when you push, and you're going to know with 92% accuracy. And you only increase your accuracy with 3% by looking for these other things, which can be kind of advanced. All right, well, here's an example of a cholecystitis patient. And here we have a gallbladder. There's definitely gallstones there, right, guys? Notice the gallbladder wall. Do you guys see the thickening of the wall there? Okay. And when we measure the gallbladder wall, we always want to measure the anterior wall because notice here, the sound waves are coming through the bile here and lighting up the posterior wall, making it hard to actually measure. There it was actually 4 millimeters, so that fulfills the criteria of greater than 3 millimeters. Okay, now you should look in both short and long axis, and actually on this clip, you can kind of see the gallbladder wall here better in short axis plane. Notice this concretion of gallstones here. And there's the thickened wall, and you can kind of see the wall there, but it really shows up better on the short axis. So that's just twisting the probe. And here's one just showing acute cholecystitis. This is the pericholecystic fluid again, the gallstone, more like the montagna. And here we have the fluid. You can see right here. And so this patient actually had acute cholecystitis. Okay, and as a final thing, now you guys should know that not all gallbladder wall thickening is due to actual infection. And the first case I saw when I started doing ultrasound was a patient who had hepatitis. And I went to the surgeons and said, I think this patient has acute cholecystitis. And they said, what's the transaminases? Then I looked in the computer, and there were like thousands. And they're like, no, this patient does not have acute cholecystitis. This patient has hepatitis with secondary thickening. But you can also see this in renal failure and liver failure, as well as nephrotic syndrome. And look at this clip. Now, this is a patient who had liver disease, right? What's all this, guys, right up here? That's all ascites, right? And there you can see the thickened gallbladder wall, but notice that there's a lack of gallstones there. Okay? One last pearl. If you see things that look like this, you need to start calling in for help. Okay? Does this have the classic look of actual stones? Not really, right? It could be small stones, but notice it's completely filling up the gallbladder. This actually turned out to be gallbladder cancer. Okay? So when you see things that look abnormal, get the official scan. Okay? We're not the ones who are going to be the be-all, end-all on these things. Okay, very good. So that ends the gallbladder section. I just have a quick couple slides on kidney. And this is a pretty frequent clinical case you may see in the ED. The patient coming in with severe right flank pain has a history of kidney stones. You dip their urine. And the next question is, what you going to do now? Okay, your options are you could do the old KUB or just manage clinically. You could do an ultrasound. You can do a CT urogram now. It's a great test, right? But, I think that this patient has a history of kidney stones. He's relatively young. One could make an argument for just doing an ultrasound, right, on this patient and just confirming that the patient has hydro and treating them clinically. Okay, so let's go over a little bit just of the anatomy, again, aside from Netter. Remember the outer cortex of the kidney, the renal pyramids as we walk our way in the medulla, the calyces. Now, this is the area where you're going to be looking for hydronephrosis, okay? And the other point here is that there's usually fat in the renal sinus, and that surrounds the calyces, giving it a hyperechoic, light appearance. And remember that the calyces come together to make the renal pelvis, and finally form the ureter. Okay, so there's our anatomy, and this is the part where we're really looking in terms of with hydronephrosis.
Let's go over how to perform the ultrasound exam of the kidney. Generally, it's best to have the patient in the decubitus position, especially on the left side. And here we're going to begin with the left kidney. Notice that I was just motioning towards the marker dot on the probe, which I have oriented towards the patient's head. Notice also that I have the probe tipped backwards, so the top of the probe is slightly posterior to measure up with the long axis plane of the kidney. I'm going to scan from the superior tip all the way down to the inferior pole of the kidney to adequately evaluate for hydronephrosis, and notice the fanning motion back and forth as I scan all the way through the renal structures. Now let's go over to the right side, and on this side the liver does offer a better acoustic window to the kidney, so it's less important to come from this posterior position, although sometimes it does help. Notice here also that I'm going to scan from the superior tip of the kidney all the way down through the inferior tip, fanning back and forth to adequately evaluate for hydronephrosis.
Okay, so hopefully you guys will have a chance to practice that today, as it's kind of a bonus as part of your FAST exam where you're going to be able to see the kidneys. So your trauma patient may have had a kidney stone, and that was the real reason they got in the car accident, right? Okay, so here's a normal kidney. This is what it looks like. And here you can see basically the outer part. Okay, so as you walk our way in, we have the outer cortex. We have the inner medullary pyramids right here. And we have the calyx. And notice that the calyx takes on a bright appearance. That's fat in the renal sinus, making it hyperechoic in ultrasound speak, or light. Okay, notice that there's no fluid in this area, and fluid is going to be anechoic or dark. So what are we looking for in terms of hydronephrosis? Well, here's a still image kind of showing you. What you're going to see is dilation of the renal calyces, and you may also see dilation of the ureter or hydroureter. Do you guys see all this right here? It's kind of a ballooned out, lots of fluid within that kidney. And you can grade hydronephrosis from where you just have some fullness of the calyces all the way to where the entire kidney becomes ballooned out by fluid. Okay? And so I like to grade it grades 1, 2, and 3. This book here said mild, moderate, and severe. So here's a grade 1. And this is probably you guys after drinking too much coffee this morning and having me bore you for an hour of ultrasound talking. You'll definitely have some fullness here of your renal calyces, okay? And you can see how they coalesce here into the renal pelvis. You guys see this right here as a scan down? Boom. All those are coalescing. So these are not just all small little cysts, okay? My residents also often come up to me and say, are those cysts? And I say, no, they're all coming together. That's hydronephrosis. So again, we have the dilated calyces. Now this one is a little bit higher grade. Notice here we can actually really see all of them coming together here. And now we can actually see the hydroureter coming down. Okay, so this would be considered moderate or grade 2 hydronephrosis. Now this poor patient was having a bad day. Okay, she had had a renal stent, and now she was having a malfunction of the stent. This is actually a stent there. And notice her kidney completely ballooned out by fluid. So she was not doing well. And the urologists were not quite sure what to do at this point because that was like her third stent. And people ask, can you see calculi? Can I see stones when I'm looking with ultrasound? The answer is yes if they're within the kidney, probably no if they're within the ureter. And this is a patient who's got a large concretion of kidney stones right here within the calyceal, the pelvic area. And what's all this out here, guys? Hydronephrosis. Very good. Okay? So this was actually an interesting type of calculus. This was your classic staghorn calculus made up of struvite that was just stuck right there in the middle of the kidney. And again, the urologists were like, lithotripsy ain't going to work for that. Okay? So they were not quite sure what to do for this one either. Another tough one. All right, so another teaching point that's very important is making a differentiation from a renal cyst from hydronephrosis. Now, a renal cyst is typically going to be more peripheral. And notice that this is a large area of fluid, and one could mistake this for hydronephrosis. But notice that it's kind of peripheral. It's disturbing the outer architecture of the kidney. And the area where I told you we need to focus our eyeballs for renal ultrasound is right in here in the calyceal area. Do you guys see dilatation of the calyx there? Not so much, right? Okay? It doesn't really look here, and we don't see hydroureter. So this was a large peripheral renal cyst, and sometimes it can get confusing. Sometimes we all struggle. This is a case of a patient who had 2 large renal cysts. They're both peripheral, but again, if your eyes look into the middle here, what's left of the kidney, you don't see the actual dilatation of the calyx. So while cysts can be a little confusing, your eye should just always go to that area of the calyx, and hopefully you're also going to see the hydroureter. All right, as a final pitfall, if you guys see things that look like this, okay, so here's the kidney, and do you guys see this area right here? there's something disturbing the outer architecture of the kidney, and it looks to be, does that look like fluid or solid to you guys? It looks more solid, right? It doesn't have that black appearance of fluid. This was actually renal cell carcinoma that was caught on one of our bedside ultrasounds, and luckily we were able to get the patient for a CAT scan. And, this is a potentially curable disease if you can catch it early, okay, if the patient can go for a nephrectomy. So when you start to see things that look abnormal, low threshold, guys, for getting a CT scan or a formal ultrasound, you may save a life. Okay, and to finish up, as the last part of your renal ultrasound exam, don't forget to scan the bladder. Okay, what if your patient has a gigantic bladder? That could be the explanation of your bilateral hydronephrosis. And as a bonus, you may get to see the stones within the bladder. Okay, this is a patient who has multiple stones within the bladder. Okay, so they look like gallstones and they're shadowing off the back. Okay, so that's the end. I know that's a lot of territory to cover. Are there any questions? Yes, in the back. Establish the ultrasound as standard of care. I think that what we're seeing now is a paradigm shift as more residents get trained in ultrasound, that it's becoming more in terms of the routine use of care. I don't think it's to the point now, if you didn't use it for a gallbladder yourself or an aorta right there, that you would get sued. That may happen in the future as more and more people get trained with it. I tend to look on the converse. I tend to look at it the opposite way, and that, I think that we can really help out a lot of our patients by using this technology and picking up disease processes early. And we're going to talk about vascular access later, but, if you're doing a central line without ultrasound and you have a complication, I'm not sure you're going to, there's a lot of articles showing that ultrasound helps with that. So, Deacon? Do you want to take mine?
I'm on? Okay. Let me just make a qualification. Is there a medical legal precedent? I'm not aware of one today, but guess what? It's going to happen tomorrow. I can picture this happening at a hospital where you have a machine sitting there, and some of the docs know how to use it and use it on a regular basis, and some of the docs don't. Somebody comes in 10 o'clock at night with an aneurysm. Dr. A does an ultrasound and gets the patient expedited, etc. Dr. B doesn't do an ultrasound. Machine is sitting there. There's radiologist called in, a tech. There's a delay. The Nighthawk. The series of errors that occurs. Patient has a bad outcome. I can see the plaintiff's attorney making an argument. Why wasn't that machine used? So that hasn't yet happened, but it could happen. I'm pretty sure at some point it will. I'm going to open up any other questions from this morning's, the trauma, the physics, any of the abdominal stuff. Yes.